I'm Ross Camidge. I'm the Director of Thoracic Oncology at the University of Colorado Cancer Center. Radiation necrosis is becoming an increasing diagnostic and therapeutic problem in modern oncology. So we have very much moved away, particularly in the field of thoracic oncology, from whole brain radiotherapy and moved much more towards highly focused radiation, so-called stereotactic radiosurgery. Now, that's really good at destroying and controlling that individual site of disease. But sometimes, many months, sometimes even years later, you might see that same lesion expand. And the question going through your head is that failure of the radiation, and this is a progressive lesion in that previously treated field, or could it be this thing called radiation necrosis? So radiation necrosis is where the radiation damages either the normal blood vessels in that area, and at some point they sclerose and clot, and they cause essentially infarction of an area of normal brain, or the radiation has damaged some of the normal brain cells, including the microglia, and they don't turn over very often. So one theory is that they don't know that they're dead until they decide to divide, and they may do that months or years later. And then when they do, that's when they then die, they necrose, they release inflammatory products, and you get inflammation. So some of the key features about radiation necrosis are it's going to be in a previously treated area, usually with high dose radiation, stereotactic radiosurgery, rather than whole brain radiotherapy. And then the question is, how do you differentiate between these things? Well, there are certain imaging features. So one of the things you might see is it's likely to be circumscribed in a sphere around where you have the stereotactic radiosurgery. Because you can get necrosis, there are certain features. There's something called soap bubbles or microcavitation that you can see. But the real question is this dead tissue causing inflammation? And there can be a lot of edema around it. Or is this actually progressive cancer? And so some of the tricks that people use is they use various aspects of magnetic resonance perfusion or magnetic resonance angiography, sometimes with a technique called arterial spin labeling, which is essentially a magnetic pulse that allows you to track a flow of blood through an area. If this is necrotic tissue, you're not expecting there to be blood vessels in there. If this is new tissue, you expect there to be new blood vessel formation. You can also do some form of functional imaging. You can do MR SPECT scanning. You can do a CNS PET scan. Again, you're not expecting it to be active. Sometimes you can't tell. So what do? Well, if there's a lot of symptoms from it, first thing you're going to do is try and treat it. Often you'll start with steroids because what's going on is you have this inflammatory stimulus. If steroids don't work, other things that you can try are bevacizumab. So this has been known in kind of single-arm studies for quite some time, 5 to 10 milligrams per kilogram, sometimes even only 2 doses, and you can somehow just shut off that inflammation. It's used by neuro-oncologists. It's not very well known, but it definitely works in some people. And if all of that fails, one of the things you can sometimes do is resect or resect that area, and that's the definitive thing because you'll just see dead tissue. The one thing you really want to sort of try and avoid, unless you're 100% sure this is progressive disease, is re-irradiating because you might just be throwing fuel on the fire.